Okay, just one other red flag might be, you guys, we can sense in ourselves, I don't know if it's transfer, whatever it is, uh-oh, not him again, not her again, something wrong, this sinking feeling, oh no, you're feeling like, I don't have a choice, I don't want to give this person this, but I'm feeling manipulated into doing something. You're feeling something is wrong, okay? This really, my first job, I was told, well, by this guy who'd done a fellowship in addiction. Well, he told me that I knew a lot more about addiction than he did. Well, I didn't know anything about addiction at that point, but I knew pain. I knew pain very well. I knew cancer pain, how it responded, what these people would look like, how they respond to medications, how they take it. And then I'd see someone who didn't fit that. Well, something is wrong here. This should be responding. It's not. Something is wrong. And how high doses are we going to need? This keeps escalating. What's going on? Why does he not tolerate anything except IV hydromorphone or whatever the drug of choice happens to be? It doesn't necessarily mean it's just something that you should be starting to think, something's bothering you. So, okay, something is wrong. If you've got something flagged here, asking them. I'll ask people, what do you notice what happens when you take the medication? What do you feel? You don't always get this, but it's amazed me how many times people will be right up front. Oh, I get this wonderful feeling that starts at the top of my head and goes gradually down to my toes. I just relax all over. All those concerns I have just go away. Well, that is euphoria. That is not pain relief. I ask them about stress. If you have a lot of stress. And stress is a neutral term, unlike depression or something like that, where they may be immovable. But are you under stress? Does this medicine help with your stress? If it helps, tell me about that. It's amazing sometimes how revealing that can be. Does that really help? Okay, well, that doesn't necessarily mean it's bad, but if they are noticing a significant effect on their stress and mood, that would be at least a yellow flag that, hey, I need to be watching out here. And you can do these other studies. Okay, there's a violation. Something seems wrong. Well, find out what's going on. So give them a chance to hang themselves. Give them a chance to explain themselves. I don't necessarily show all my cards right off the bat. And I may say, tell me about, I know that they have gone to 3 ERs. Okay, how have you been doing? Have you gotten any from any other sources? And they get this whole story. And then you give them, this is something I have, and suddenly the whole story changes. Again, they have a good piece of information there. Now you're not looking to trap people, okay? The goal is to give them, and sometimes you will find out that, this doctor said they think this, and I saw this, I hear their story, okay, it makes sense, fine. But at least that way you're finding out. Ask them, confront them with your thing gently. I'll move quickly, I'm almost done. Now we've got the problem. We found, there's been a clear violation. What do we do? Something's wrong. And we need to find out how bad is it, and is there evidence of need or benefit from this medication? Now let's say, first of all, extremely uncool stuff. All right, they're taking your script and they're forging it and they're turning it in. They are selling your medications on the street. The DEA comes to you and says, hey, we found this, we bought this on the street for $30. Okay, that you discharge. You cannot have someone in your practice who is doing that. That's just unacceptable. You have to do the 30-day notice and all that kind of stuff, the certified letter, do all that. You guys probably know it. Clear cut, no problem. Well, now we've got almost as bad. They've lied to you. They clearly lied to you. Or they're clearly misusing drugs. They told you they weren't, but they're shooting heroin and cocaine. They saw 3 other doctors and they didn't tell you about it. You're clearly seeing that they are abusing medication. What do you do? Well, I've had physicians very proudly say, we give out opiates, but we very carefully screen everyone, and as soon as there's anything wrong, we kick them out of our practice. Okay. There's glee in his voice. Okay. Do you also screen everyone for, say, HIV or some other medical problem, and then as soon as they're positive, kick them out of your practice? We just found this person has a serious issue, which is a life-threatening problem, which is potentially destroying their life, a huge medical issue. You're just going to discharge them? Now, these people need help. They need a lot of help. Now, they do not, perhaps, probably need opiates, okay? Which is what they think they need. But they do need help. And I personally think if you're just discharging these people like that, that is malpractice. I do not feel that that's appropriate, just like that. Now, one thing that's key is it is not about me. It is very easy to be offended, to be hurt, to feel betrayed, to feel all these emotions. The fact is, it has nothing to do with me. This person feels like if they don't get this medicine, they will die. And so they'll do anything it takes. And they are good. And they may have talked to other people about how to tell me the right things. And I was doing my thing. Yeah, I can look back and say, is there something I can learn from this? Should I do differently in the future? But I do not want to then feel like, oh, well, I'm not going to give anyone opiates because this one person, I'm going to withhold it from this other person because this person likes it. No, it's not about me. It's about this person in front of us. And we need to deal with that and let those go. We need to be firm and compassionate, both. Understanding that they're but for the grace of God, but also firm. Ask them questions. I'll sometimes ask them, again, I'll ask them about the effects of opiates and see if they're seeing some of the downsides of them. And sometimes they can be quite revealing on that. And then explain why you believe it's harming them, including that dysphoria. This is making you feel worse. You feel like it's making you feel better, but in the end it's actually making you feel worse, and it's just harming your life. Do they need to be detoxed? I mean, are they going to go into a severe withdrawal syndrome if they stop smoking? Are they going to go to AA or NA? Would they benefit from a maintenance program? Offer to treat their pain. I want to take care of you. I want to treat your pain. I am not going to use opiates for your pain because I believe at this point those are going to do more harm than good. If you are going to, it would be a very, very specific type of drug. And the reason I'm not giving it is not because you broke my trust, so I'm going to get back at you and not give you opiates. The issue is, I believe this is harming you, and I cannot, in good conscience, do something that's harming you. Okay, now those were the extreme. They're clearly lined. Now this is a problem. They're running out early. You know, they're taking extra. They're really pushing it. They're rapidly escalating dose. You're really concerned about this. It doesn't seem to be working. Again, ask some questions, explore it, then you can explain your concerns gently and firmly. You can reevaluate. Oh, this is one thing: pseudo addiction. I have seen, and one friend who was actually a lawyer, but a friend of mine never had any pain in his life, developed shingles into his ear, excruciating pain, to the point that his wife called my wife saying he's considering suicide. And his doctor, he was going to his doctor and asking for more pain meds. His doctor was giving him Vicodin 4 times a day, and he was asking for more, and the doctor was convinced he was drug seeking. He actually said that. No, this guy was not drug seeking. He was in excruciating pain. And he needed more medication, not just opiates. He needed a whole range of appropriate medication, not less. Now, don't just give it out. I mean, use your mind. But that is not, that picks that patient. I mean, I actually am kind of embarrassed, but I actually told a lawyer that that was malpractice. He didn't, he wasn't. I was like, I can't believe he's doing that. But no, that was not. And this guy was showing some signs. He was showing some. He was actually using alcohol at the same time. He was doing anything he could to try to deal with his pain. He was taking alcohol, which he had never had a problem with. He was taking drugs and hoarding, and he was doing everything he could to try to deal with it. Well, it was not addiction; it was pseudo addiction. But if that's not what's going on, which happens, again, that guy with gout, that was pseudo addiction. Was a guy on a steady level. He was fine. Don't be nice to them. Okay, being nice is not loving. It's not kind. Be considerate and be compassionate, but you also need to be firm. Are they clearly getting benefit from it, from the opiates? Not. Maybe we'd best off taking a different strategy. If they are, you want to focus on sustained release only and that type of thing to minimize euphoria. So I've had people say, well, why do that? Why don't you just fire them from your practice? Why do you take this time to try to deal with people who are addicts? They're just addicts. Well, no. These are people who are hurting. People like you and me. I've met 4 physicians who are opiate addicts. And they're some of the people I've liked every single one of them very much. Won't they behave? Actually, I have found, and they'll suffer. Oh, won't they suffer? Can be less rewarding. You won't make a difference. They're just addicts. Well, some of them you don't fix, but at least you won't get harm. Some of them you will help. I've found much positive response I've got, as I've been very firm with a lot of people. And basically, I mean, this is a mission of the places where they call me for these challenging pain situations, but I often say, look, we're not going to do this anymore, this is the plan. But because I talked to them and showed it, I was trying to help them explain why. Well, they were talking to me. Thank you so much. And that was after I told this person that they were an addict. And both basically more so many words. I said, I think you have a real problem with these medications. I don't necessarily diagnose addiction for the most part, but I clearly do. I do recognize that they have a problem with medications. You know, I've had people, they really were resistant. It took a lot of work to get them through that hard phase. But acknowledging how much better they're doing now that they're on a steady level of opiates. Can't believe how well my wife is doing. I really appreciate it. I'll go back. And these people leave your practice. Okay, they're welcome to fire themselves. It's not about you. They can go, and they know if they want to come back, and you'll be happy to take care of them and treat them with adjuvants and try to help them out and get them the treatment they need for their problem. Great. Well, they have a way out now because you are being compassionate and you have helped them have a direction to get. And you've told them that they have a problem, and so that they can actually start getting it. So this is very rewarding, unless your goal is to eliminate all pain or to release the patient. Okay? That's just not. We want to alleviate suffering, prevent harm, and this helps patients, physicians, and families. In conclusion, both pain and opiate misuse are a major problem in society for patients. It harms the individual person. It's not a moral issue, and it's not about us. It is the best care for a suffering person. We need to evaluate patients' pain for the opiates. Don't use it for everyone with chronic pain. It's not going to work for everyone with chronic pain. If it's not working, stop it, take a different strategy. Keep in mind risk factors. Be aware of expectations of chronic malignant pain. You're not going to eliminate pain. Focus on the function, what they can do. Analgesics, holistic approach. Aiming for steady blood levels if we are using opiates. Explicit ground rules, which you're holding them to. Benefit, focusing on function again. Evidence of misuse or abuse. Evaluate the severity. Confirming compassionate. Discharge only in the extreme situations. In some, if they're clearly violation of trust, you cannot trust them to tell you the truth, and you cannot continue prescribing opiates until you take care of them, help them understand that they have a problem, get them the help they need, whether or not they want. And I would argue that I have found dealing with this interface of abuse and addiction has been amazingly rewarding. Not everyone has done wonderful, not everyone loves me, but I've had patients that have appreciated me even when they haven't followed my plan, and I've been able to help other doctors and patients.